Thank you all for being here. We'll get into it. Dave, why don't you tell the room a little bit about yourself and about Sanford Health if they don't already know?
Sure, absolutely. So I'm Dave Newman. I'm the Chief Medical Officer of Virtual Care at Sanford Health. So Sanford Health is the world's largest rural healthcare system. We're also one of the largest healthcare systems in general. We're an integrated healthcare system. So we've got a healthcare plan. We've got data analytics. We have about 5,000 providers. We serve 2 million patients. We're in 11 states, and we have about 55 hospitals. One of the things that we've been super excited about is leaning into virtual care and technology, and that's why I'm excited to be here.
Awesome. Well, yeah, we'll be talking about technology, AI, virtual care, telehealth, all the things. But I really do want to focus first on virtual care because I know Sanford has been such a pioneer in it, and we'll be talking about it in that unique rural context because being a patient in rural America is kind of difficult. If you ever find yourself in a rural area and you hear about all these hospital closures, when a community hospital closes in a rural area, residents in that locale go from having an emergency department, 10, 15 minutes away to an hour away. And that really changes a stroke or heart attack patient from someone who survives to someone who has, a fatal incident there. And it's not just in these emergency situations. Getting routine or any specialty care can be really difficult too with these long wait lists and with I don't want to make it seem like everyone in rural America is poor or farmer because that's not the case. But oftentimes these are very hardworking, lower income people who can't take a day off or a half day off, lose those wages to go, see a specialist or pay for all that gas for a 5-hour round trip. So virtual care can be such a game changer. And I know that Sanford has really been a pioneer in this before the pandemic, before it popped off. So can you just start by talking a little bit how you define virtual care, what some of those different modalities, use cases have looked like?
Sure, absolutely. So we define virtual care as anything that's not face-to-face. So when a lot of people hear virtual care, they think about telemedicine. They think about virtual visits. They think of the traditional seeing a patient through FaceTime or through your computer when they're at home or if you're at a clinic. We have gone several steps past that, and we do lots of e-visits, which are questionnaires that you can do. We do remote patient monitoring. One of the biggest problems in rural America is access to subspecialists. So now at our critical access hospitals, they have remote consults that we do. So I'm an endocrinologist. Have you guys ever been to North Dakota? Has anyone been to North Dakota? Oh, right. Have you been there in the winter? No, we have somebody. So it is brutal. So there's like 4 endocrinologists in the state. It is roughly a year to get in to see me. It is completely unacceptable if there's a blizzard and you can't drive the 6 hours that you were going to drive to see me to get rescheduled for a year, right? Absolutely unacceptable. So we figured we were going to treat them regardless of their zip code. So now if you can do a video visit, I'll see you by a video visit. If you want to do an e-visit, we'll do that. I have a patient that lives in Dickinson, North Dakota. Small town, he's a rancher. He lives on a ranch by himself. He has a rotary phone. I'm not joking, like old school rotary, dial like this. If you remember the 70s and the 80s, it has a cable that's like 20 feet long. And I do virtual care that way. I deliver care through his rotary phone. It's pretty amazing.
I wonder if you can share some of the success stories for patients like that, or, I'm assuming that these virtual care programs improve things like patient satisfaction and, avoidable or preventable hospitalizations, but could it also save money for a health system like Sanford as well?
Absolutely. So let's talk about the patient first. So we have done a study on our impact of virtual care in our own footprint. We saw that it saved roughly 176 miles per patient, which when you look at the economic impact on that, it's $300 per virtual visit saved. Massive, massive savings. If a lot of people in the earlier sessions were talking about ROI. So we look at ROI for us as well. So we're an integrated healthcare system. For our Medicare Advantage patients, we take on liability for them. We stood up a primary care virtual visits for risk stratification and to close care gaps. So this is for patients that we're responsible for. We have free virtual visits for them. We actually incentivize them. We give them a $50 gift card to send on groceries. And this is so they stay in the system, that we can get them their colonoscopies, that we can get their problem list updated, that we have a pharmacist meet with them so there's accurate med lists. These are how that we're innovating really out of necessity, because in rural America, it's often virtual care or no care at all.
I wonder how you balance this innovation with some of the realities about, rural broadband access, about the digital divide, people's comfortability with using technologies. You've certainly kind of mentioned that with the rotary phone example, but, when you're dealing with this population that spans so many states, how do you kind of approach that?
So we thought it was going to be a bigger deal than it actually has been for broadband access. So in the Dakotas, we've got vast areas where there's very small populations. We've got Native American reservations. We've got areas that are maternity deserts, that are mental health deserts. And it ended out that roughly 99% of our patients have access to broadband. And they have a smartphone or they have another device that they can do this from. That wasn't one of the biggest barriers. The biggest barrier has been a lack of digital literacy. So they didn't really want to do these things. And on the providers, so doing the change management on the providers. One of my buddies, his name is Adam Jackson. He's an MD, PhD neurosurgeon. If you've ever dealt with neurosurgeons, they can be interesting. He flat out told me, he's like, Dave, I'm never, ever going to do virtual care. This is stupid. I can do the same thing in my office. And then we had a blizzard. And on his post-op clinic day, which he does twice a month, he wasn't going to get to see any of his patients. And so at 6:15 in the morning, my phone goes off, and he kind of sheepishly put his tail between his legs and says, Dave, I think I need to do this virtual care thing. And it was easy for him. It was just because he was comfortable with the technology, it was easy for him. It's not easy for everybody, right? I am a realist. I ask my patients, have you ever FaceTimed your grandkids? If they say yes, I say you're suitable for a virtual visit. I ask people, have you ever ordered anything from your phone from Amazon? If they say yes, I say you can probably do a video visit. It's going to be okay.
This commitment to meeting patients where they are, in an effort to improve preventive care and improve their health outcomes, this is something that I don't think just providers are paying attention to. I'm starting to hear more payers, I think, because it can save costs, pay attention to this as well. What does that look like from your perspective? Do you think payers are starting to really understand the value in this type of work? Yeah,
absolutely. So there's some payers where they are, like Sanford, where they're vertical institutions where they have their own health plan that do a virtual first model to try to save costs, so to try to keep people in network. So if you need to see some sort of subspecialist or primary care, you can do your own providers first, which helps a lot. One of the biggest things we're monitoring very, very closely in the United States is the telehealth waivers. So right now, we keep getting like 3 months, 6 months, 1 year extensions for getting reimbursed for this. We know the value at Sanford. We've studied this. We know that we're going to do this regardless of the coverage, but it isn't like that for every healthcare system. So if you are interested in political activism, contact your local senators, your representatives, and tell them to make the telehealth waivers permanent.
Excellent. Shifting gears a bit, I know Sanford is very committed to innovation, and with a mindset like that, the work never stops. So I want to learn more about the cloud-based hospital and how you're hiring all these digital pathologists to staff it.
Yeah. So we struggle, I don't know why, the weather's great in Fargo in the winter, to recruit doctors to our area. It's even harder to get subspecialists. One of the hardest doctor to recruit right now is radiologists. We are down about 20 radiologists in our footprint. So we decided that we were going to think differently. So we started a cloud-based hospital. When you think about traditional hospitals, they're brick and mortar. They are buildings that are set up. Great, we need these. We need these when people are sick. Not all doctors have face-to-face roles. So we switched a lot of our radiologists to be virtual radiologists. So you can be in Hawaii and you can read films in North Dakota. And you can read for overnight films that need to be read from the ER, and you can be in your pajamas in Hawaii. It has been much easier for us to recruit those areas and serve our patients. We have enterprise credentialing now. So if you work at hospital systems, you know how huge of a barrier credentialing is. If you work for a large system and you have many hospitals, the providers need to be credentialed at every single hospital. By doing this through an enterprise system, the cloud-based hospital, we already have saved thousands of hours of administrative burden, and we've been able to get care to the patients sooner rather than later.
I wonder, how the pathologists, the radiologists that you're hiring are reacting to this, because there's obviously a huge workforce problem, and a lot of people are exiting these healthcare roles sooner than they would because of all the burnout. And this seems like it kind of, fits into their lifestyle, gives them the flexibility and options that we're seeing so many health systems pay more attention to when it comes to their workforce. Can you share any feedback you've gotten from people in these roles?
Yeah, so literally this morning, I interviewed a radiologist that was only looking at virtual positions. He was coming out of the Brigham and he said, this is what I want to do. I'm only going to entertain these options. Last week, I had a doctor, a family practice doctor. He had practiced for 42 years. He was trying to decelerate. He was trying to do less work. He wanted to see patients a couple days a week, but he also wanted to snowbird. He wanted to spend winters in Arizona. Get him an Arizona license, he's going to see patients virtually 1 day a week from Arizona. So we're keeping people in the workforce and we're making their life better, is what we're doing.
A lot of the AI tools that hospitals are adopting, and even a lot of the discussions we've had up here today, focus on reducing burnout and just making a healthcare job something that people want to come in and do every day and actually feel like they're helping people rather than just being bogged down and administrative tasks. I wonder if you have any other examples of AI tools that are helping solve this issue.
Yeah, so at Sanford, I'd say we are more progressive in AI than a lot of other healthcare systems. So we have to do it. We've got workforce shortages. We've got access problems. We need to keep the doctors happy where we have them. I know a lot of talk has gone on ambient AI. And if you haven't seen this, it's way better than you think it is. So the time that I get the most people emailing me and calling my phone being unhappy is when our ambient AI goes down. If you think back to high school or college, you think about like doing homework. Homework's horrible. At this point, the average doctor does 2.5 hours of paperwork after they're done seeing patients. We can decrease that at least by half, sometimes even more than half, by using ambient AI. We have our own inpatient AI team, so we have predictive analytics, and we've had predictive analytics for about 8 years. We've only been able to operationalize 2 of them. So when the people before were talking about change management, having the vendors involved in that, that's what we need. So we have an awesome algorithm that we've had for 8 years on how to predict chronic kidney disease. The issue was getting it to the provider so they could get it to the patient. Just recently, we got this implemented into our EMR, so it's front and center, and the doctors can see this. They can order the appropriate tests, and they can order the appropriate medications to hopefully prevent patients from progressing to end-stage kidney disease and keep them off dialysis.
I wonder, when you're adopting these AI tools, I often hear from health systems how important it is to involve the end user, the nurses, doctors who are going to be using that. And I'm always interested to hear, what that looks like at each health system, because it always looks a little different. But, I hear a lot of committees being stand up and kind of these regular meetings where you want the feedback. What are your pain points? What can we do when we're having, these purchasing meetings and making decisions as an organization? How can we incorporate your voice? So what does that look like at Sanford?
So I'm like considered a tech bro. Like I'm really into AI and technology. But the thing that helps the most is honestly just using your phone and making phone calls. So the times that I've gotten into trouble the most is when I didn't make the appropriate phone calls before I made a decision. So if I am rolling out a digital stethoscope, I've done this before, if I don't talk to cardiology and pulmonology beforehand, it's not going to be successful. And I'd like to do a lot of those meetings face-to-face, even though I'm a virtual guy, but it's the relationship aspect that sells the technology. That if you don't have that aspect, and if it typically in healthcare, doctors listen to doctors, nurses listen to nurses, so it's getting the right people in the room to start with.
Still speaking about, these purchasing decisions, I'm sure you get pitched a lot of different AI tools and a lot of different pieces of healthcare technology. Do you have any common pet peeves or things that kind of annoy you in these meetings, or something that you just want to stop seeing?
Facts and figures that are not realistic. Yeah, man. Like you come in and I've been pitched by companies that say they're going to save me $300 million. You're not going to save me $300 million. If you have clinical data and it's been peer reviewed, lead with that. That right now we've got tons of journals. So the New England Journal has an AI peer reviewed journal that just yesterday, or not yesterday, on Monday, what day is today? Thursday. On Monday I was in clinic and I hadn't been there a while, and so I had a stack of journals that I hadn't read yet. New England Journal, Annals of Internal Medicine, Lancet, high impact journals, every single one of them had an AI story. Every single one of them had how AI is going to impact that. If you have those things, put them on your front page. That is how you get your foot in the door.
I also wanted to open this up to the room if anyone has any questions for Dave. Well, there's a mic back. Oh, there you go.
Your first example of saying there's 4 endocrinologists in the state of North Dakota. Oh, yeah. 4 endocrinologists in the state of North Dakota. You opened up virtual care. You're able to provide care to a lot more people, right? You said you had a 1-year wait time there. I think there's about 100 million people in North Dakota. The incidence of diabetes is about 10%. Like, how did you navigate then getting licenses for? Is it still the same 4 of you? Is it you have to increase your staff? How does that work?
Yeah, so great question. So we utilize the Interstate License Compact. So for medical licenses, you can have a single state support you, and then the other states will use their data to get your license in other states. So I've got license in multiple states. As far as how do we get to see the patients, we're using lots of different methods. So we have nurse practitioners that are trained to see the patients virtually. We have remote telemedicine clinics just for diabetes. On the AI front, so if you haven't heard about artificial pancreases, so insulin pumps with sensors, it's got to be the best AI use case there is in medicine right now. So in my life, I went from struggling to get patients their diabetes controlled because their pancreas doesn't work to just verifying that they were charging their pump and filling with insulin. That in my lifetime, it has been the single greatest success story for diabetes management.
Anyone else? Okay. Oh, we have one over here.
Great quotes. I appreciate just the relatability of how you expressed what it's like to be in North Dakota. So thank you so much for that. Virtual care is great, but there are places where you can't, or situations where you can't do that. We're going to need a live person. How are you guys augmenting all of that with different things, and how do you think about staffing? Obviously, locum tenens is a bad word. Nobody likes that. But how do you think about fractional care in your setting?
A super great question. So we know virtual care isn't great for everybody. We are seeing a huge rise in demand for virtual support systems, though. So you think about an ER. You can't do virtual care ER, or can you? So right now, our critical access hospitals, we support 19 critical access hospitals. That's typically a nurse practitioner or a physician's assistant or a family medicine in a small town. Somebody comes in, it can be very scary to keep the patient there. You're worried about this, right? So we have a program, you hit a button on the wall, and an ER doctor in Sioux Falls, South Dakota, a board-certified ER doctor, comes up on the screen. So they are able to walk you through what to do with the patient. They're able to tell you if you should transfer the patient or not. And if you do transfer the patient to Sioux Falls, it's the same doctor that's treating the patient. So this has been a win for everybody because our ERs are full. We get to keep people in the critical access hospitals. The critical access hospital gets to keep the patient, keep the revenue, and the patient gets to stay where they want to be. And instead of having to have a 4-hour drive to Sioux Falls, South Dakota, to be discharged later in the day, they can stay closer to work and they can, let their dog out or do whatever they need to do. Great question, though.
Do we have any other audience members with questions? If not, it's okay. I can ask more. Oh, we have one.
I had a question related to your virtual care telemedicine. Is it still being reimbursed through Medicare?
Yeah, it's absolutely being reimbursed. It's actually for, you get just about the exact same reimbursement as you do for in-person, and for your providers that are RVU-based, it's the same amount of RVUs.
That includes a phone call, just a phone call?
Oh, no. So great question. So clarifying, a verbal visit is reimbursed at much lower.
Right. But is it still reimbursed?
It's still reimbursable. Yeah, so I provide a lot of care to like the North Dakota State Penitentiary, and I do a lot of verbal visits that way. There are certain instances where it's just the easiest thing to do, and it's the right thing to do, and so we do it for that way.
So I'm an oncologist, and in oncology, of course, you need to go to a place to get chemotherapy, radiation, or surgery for that matter. But aftercare, survivorship is a space that I think virtual care would really work well.
Oh man, this will blow your mind.
Yeah.
As far as how much time do we have, Katie?
5 minutes.
5 minutes. Okay. So Lidgerwood, North Dakota, town of 600 people. They had a clinic, but we couldn't staff it because there weren't a lot of doctors that wanted to live in a town of 600 people. So we had a building underutilized. we were like, let's make this a virtual clinic. So we flipped it to virtual. We put a nurse in there. Patient would come to this clinic, be roomed, and so they didn't have to worry about digital literacy, whatever. It wasn't really utilized, and we didn't know why. Patients weren't going to it. So I decided to drive to Lidgerwood one day, and I had lunch at the one lunch counter they had. I went to the coffee shop and had a cup of coffee. I had a beer at the bar, and all the people there said the same thing, is they wanted their subspecialists, that they were okay to see their primary care doctor that was 5 towns away, but they didn't want to drive all the way to Fargo to see like their oncologist. So within 2 weeks, we pivoted to subspecialists. So now you can see your endocrinologist, your oncologist, your ENT doctor, all these different doctors in Lidgerwood, North Dakota. Oncology was huge. So I came back to see how it was going 6 months later, and the same coffee shop owner, she came over and she gave me a huge hug. And she said, I'm going through treatment for breast cancer right now, and I have to see my oncologist every month and get labs every month. Now she walks across the street to our telemedicine clinic and gets her blood drawn. If she needs to get imaging, we can do it there, and she can see her provider remotely. This has saved her like 14 days of vacation. You talk about survivorship, same thing. We're doing virtual survivorship clinics now.
That's excellent. I'd be willing to come to North Dakota.
Yeah, or we can talk wherever you are. If you're in 37 states, I can hire you. Yes, yeah.
We probably have time for one more. Go again.
Hey Dave, thanks for the time. Can you talk to working with community-based resources like CBOs, or now we see a lot of models with EMS, firefighters, you have paramedics now in the field, and how that's augmenting some of your work in virtual care?
Yeah, so we see it as absolutely essential partners. So we figure in lots of rural America, they are the provider, right? So we need to give them the help that they need. Whether it is, we just started looking at this a couple weeks ago, is virtual reality goggles, so we can give them just-in-time trainings. So if you are a PA or an EMS provider that has put in a couple chest tubes in your career, but you forgot how to do it, and you get a call, you need to do this, can you put on virtual reality goggles, learn how to do it, and then do it again to your patients? It is getting them access to subspecialty. It is getting them access to care algorithms that increase your confidence. Those are all things that are super, super important in rural America. It's a great question.
I think we can end here with a little bit of a look toward the future. I know that there's a lot of work that's been done already to help fill some of these care access gaps in our rural communities. But I wonder if we look ahead 5-10 years, what you would like things to look like and your vision for improvement.
So I'm really looking forward to having more data, more meaningful data on this, more peer-reviewed data, because that is the way that we change the providers' minds. Right now, everyone in this room knows that this is the future. We know that patients want this. It is really the healthcare systems that we're trying to change at this point.
Excellent. Well, with that, looks like we're all out of time. I want to thank everyone for your attention, and thank you, Dave, for your insight.
Absolutely.